usual reminder, record these meetings for taking purposes. So I like to start these off just by reminding everyone why we're here, but you all know we're here to work on value plan standards for 2026. So we're looking at cost sharing, health equity, suggestions from prior years. And today's goal in particular is to look at the first round of plan designs from our actuaries. I also want to take a minute at the top here just to make sure everybody knows I have not forgotten about the additional data analysis that this group has requested. We are still working on those and they'll be presented at an upcoming meeting. And I also want to just say, since we're in the first year of the fully standardized plans, although you haven't seen that analysis yet, it's not going to make a difference to the designs that we finalize for 2026. So since this is a recurring group, there will be many opportunities to look at data as it emerges and decide, later if we need big changes based on that analysis. But for now, I just want to make sure we'll close the loop on that. We'll get you the analysis, but for now, I'm comfortable sharing these designs with you, and believe that we should be able to have a good conversation about it, despite the fact that we're still working on those analyses. So, Evelyn, yes.
So, Becca, I just want to clarify. So, although this group has requested additional information, the information that we receive and are able to review in subsequent meetings really won't impact the data as it's presented today. So we could basically make a decision if we answer all of our questions today with the data that's being presented, because nothing will change that data from the subsequent meetings that we have, correct?
Yep, that's correct.
Okay, and the deadline for this is September 3rd, and the Standing Advisory Committee meets September 12th. So if we could make a decision today, that would be great, because nothing is going to impact the data that we currently have. Any information that we receive subsequently will just be for informational purposes and decision making in the future.
Yep, that's correct. There will be, I think there's maybe one option that we might that we'll want to discuss today, and then people will, I'm sure, want to digest the plans, the designs that we talk about today. But I appreciate, yes, that the note about the expediency of decision making being important. So yeah, great, thank you for that, Evelyn. Any other thoughts before we move on? Lisa.
Yes, hi, how are you? I was traveling at the last meeting, so I was only able to attend part of it, and then I got kicked out. So I hope what I'm saying is not duplicating anything that you discussed. But I talked to a couple other brokers that I work with on the exchange, and they did want me to bring up these couple things based on your notes. One was the disparity between copays for mental health coverage between plans. Some of the gold plans with one carrier, obviously, if they're getting mental health, we're leaning toward that because there's a zero copay if they're getting a good amount of mental health coverage, like weekly. Some of the mental health coverage, though, goes up to as high as $75 per visit. That's the one not subject to deductible on some of those plans, which could be extremely high for somebody that's going weekly for mental health coverage. Also, they were concerned about the lack of providers, mental health providers available between carriers. Some of the different mental health providers we've been checking only take Blue Cross Blue Shield. They don't work with other carriers. So that's been a little bit of a struggle for people that do get mental health coverage, finding a carrier or finding, if they're seeing somebody they want to stay with, they're limited a lot to the exchange plans that they can get. The other question I had was regarding chronic medications for diabetes and chronic illness. Like with Medicare, as you know, there was a law that went in for diabetic medications. They can't charge more than $35 a month copay. Is there some kind of a limit for chronic medications with exchange plans as well? And those are my
Okay.
three.
Thanks, Lisa. Okay, so what I'm hearing is there is a high deductible on copays for mental health services in some plans. You're concerned about, and you and your colleagues are concerned about network availability for mental health care in marketplace plans, and then also you're wondering if there's a cap on cost sharing for chronic condition medications like there is for diabetes medication. So I'll address those separately. So it's it's really too bad that there is high cost sharing on mental health care in some plans. I will say that in the value plans, in all our value plan designs for all meta levels, there is pre-deductible cost sharing for mental health care, office visits and services. And I believe, and we'll look at the designs a little later, we can clarify, but I believe that it's no more than a $35 copay for mental health care, even in the bronze plans and the value plans. But I hear you on the high post-deductible copays in some of the other plans. Perhaps far down the line, something we can talk about is so some states standardize all of their plans on exchange. So the exchange will have full control over cost sharing in all plans. And we certainly have, even without doing that, without standardizing all of our plans, we certainly do have authority to have plan certification standards. So that's something that, maybe our standing advisory committee can discuss about maybe, talking about the high cost of mental health care in other plans. But just for everyone's knowledge, the value plans do have lower pre-deductible mental health copays. Hear you also on the kind of limited availability of mental health care in some plans. And yeah, that's too bad. It's also something that we can talk about in another venue, but definitely appreciate the concern there. It's only so helpful to have low cost sharing if you can't access a provider. So I hear that. And then on the chronic medication for chronic conditions, to my knowledge, I don't think there is a cap like there is for insulin, but I can do some looking into that because it's an interesting idea. That's an interesting idea, but I'm not sure off the top of my head. But I don't believe so, but I can double check. Any other thoughts?
Becca, can we hold the discussion until after we approve the minutes and get into the discussion piece of it?
Sure thing. Yeah. Yeah. So we've talked about the agenda. So yeah. Moving on to the minutes. Does anyone have any comments on the minutes before Evelyn makes a motion?
So if there are no questions or concerns about the minutes, I move to approve the minutes of the June 25th, 2024 work plan group as presented. Do I have a second?
Second.
Thank you. Any discussions or questions? All in favor?
Aye.
Any opposed? The minutes have been approved, Becca.
Great. Thanks, everybody. All right. So we're going to jump into these designs. Just as context, we have previously discussed this approach of reducing cost sharing for labs. This is because of some concerns that some of you had around adding more conditions, like we've done for diabetes care, adding more reduced cost sharing for additional conditions based on the experience of DC, where they've had to really hike cost sharing for other kind of just standard types of care in order to make room for those additional conditions, and then also the logistical challenges with having to rely on diagnosis codes in order to make sure that patient care is accurately covered by the plan. So we kind of had some agreement around exploring the approach that Connecticut uses, which is to reduce cost sharing for labs, because labs are something that people with maybe multiple comorbidities, multiple chronic conditions, which tend to be high disparity conditions, will probably need to use a lot of in order to manage their care. So, or manage their condition. So we went ahead and asked our actuaries if they could reduce the copays for our value plans for lab costs. So to summarize, we were able to get a bit of a reduction, especially in our less generous plans. So, but to start just at the top with gold, gold was one where it was tough to reduce the copay without making any other changes to cost sharing. So we have two options to discuss there ultimately, which one is to leave the copay at $25, which is, on the low side. And then the other option would be to increase in another area, so the specialist copay by $5, so that we can then reduce labs by $5. So that's just something that the group can discuss, whether it's worthwhile to make a change like that or if we should keep things as is. Then for the two most generous silver cost sharing reduction plans, there wasn't enough room in the AV. So the copays remain $5 for the silver 94 plan and $25 for the silver 87 plan. But then in the silver 73 base silver plan and bronze plan, they were able to reduce the copay from $80 to $45, which looks a lot better than 80, in my opinion. But I'm excited to hear what you guys think. So I also want to just note before I show you more details, the actuaries based these designs on the final 2025 designs that we put a lot of work into designing and finalizing. So those have a pretty carefully balanced mix of all the other copays. So that's why it is it's a lighter lift for us to be able to just look at a couple of different services instead of having to look at all of the copays and balance everything. But so it's based on the 2025 designs. We have accounted for the fact that we are continuing the reduced cost sharing for diabetes care management. And there are some additional standardized service categories that we'll want to discuss that aren't part of the AV calculator, but those we'll discuss next time. But I just want to make sure, I believe it was one of the carriers that had asked for a change to the pediatric dental cost sharing, but we'll talk about that next time after we have nailed down the AV calculator portion of the design. And then, as we've discussed, we'll have to run these through the 2026 draft AV calculator when it comes out in the winter, and you may need to adjust, but we just can't know how that'll need to be adjusted at this point. And I will share these slides after the meeting so that everybody can, have something to look at as they process what we're talking about right now. So just all of those caveats. So first, as I mentioned, we have an option for gold. We could leave it as is, which the 2025 design is there on the left, the left-hand yellow column, or we can kind of move the copay around, basically hike specialists by 5 so that we can reduce the labs by 5, and that's something we can talk about. And you can see here for reference later, just the cost sharing for everything else for all the other AV services. And I'm just going to move on to the other ones. So if anyone has anything they want to talk about, feel free to stop me. But next up, here's the Silver 73. This is one where we don't have to make any changes to the other cost sharing to reduce the lab copay to $45. And it does, increase the AV a little bit, but there should be enough room still for the diabetes services. The base silver looks pretty much the same, increases AV a little bit, but reduces the lab copay by a lot. And basically the same thing for bronze. $45 copay there as well. So yeah, that's it. Happy to answer any questions you might have, but I'm mostly just really interested in everybody's thoughts.
Becca,
Yeah.
can you go back to the gold slide so we can just see it on the page?
Yep.
Thank you.
Mhm. Evelyn.
Thank you, Becca. So basically, with the gold, we're increasing the deductible by $5 for specialist visits and decreasing the co-payment for lab visits by $5. So it's really kind of like a wash. Okay.
Yep, that's correct.
I think that's going to be a hard one to kind of navigate because you don't know if they have more specialist visits or more labs. So where is the real benefit? Is it, I'm not sure if it makes that much of a difference.
Yeah, that's true.
Maybe this is more psychological, but for me, seeing the specialists go from 35 to 40 feels like such a big increase. Seeing it go from 30 something to 40 versus seeing the labs go from 25 to 20 doesn't feel like that big of a decrease for me because it's still 20 something. I mean, I guess that's just psychology, but just as regular person off the street, I feel like I'd rather keep it the way it is.
That's good feedback. And I mean, yeah, that speaks to a good point, which is that there's value in continuity. And it's nice to not change things up on people year to year. Yeah. Michelle.
Thank you, Becca. Do we have any, and you may have gone over this before, but do we have any utilization data to tell us for gold plans? Do we have more specialist visits versus more lab visits?
I don't have that information right now, but that's something that we can look into.
Yeah, and even if, I mean, we've got, I think, all three medical carriers represented here. Even if they could help us out with saying, on these gold on exchange plans, are you, what do we see more of? Because then that would help us make that decision if we're seeing, and I'll just use any number, 2,000 labs versus 50 specialist visits. And I know these are not accurate numbers, but that would help us kind of weight where this might be based on utilization.
Thanks, Michelle. That's a good point. Yeah, we can look into that. But yeah, carriers, if you have any insights, we'd love to hear them. But I see Nikki from Care First has her hand up.
Thanks, Becca. I know you have the AV estimates there at the top. So just regarding timing, are we thinking that the impact on these will be within the range? I'm just thinking about like any changes we might have to make once, the draft AV comes out.
Sorry, what's the question? Can you restate?
Yeah, sorry, my voice is a little hoarse. It's around just the timing of us, deciding on some of this. I know we're still early in the process, but are we thinking that once the AV calculator is finalized, that the changes that we're estimating here will be so minimal that they will fit into the final AV?
Oh, I see. Yeah, so yeah, basically we're using the 2025 calculator to approximate what we think the AV impact might be for these 2026 designs. But yeah, knowing that the draft 2026 calculator doesn't come out until December. What we'll do at that point is run the designs through the 2026 calculator, and then we will, or there's a likelihood that we will have to have an ad hoc meeting in December or January to talk about any changes that we might need to make so that the plans comply with the 2026 calculator. So this is basically just the best we can do right now, but so it's not going to be this exact AV. You're right. Ultimately, it will be probably something slightly different, but this is what we can approximate for now. Does that help?
That does help. Thank you.
Okay, great. Yeah, thank you for that. David.
Yeah, I just want to throw into the discussion that this is the gold plan. I'm less interested in the costs of things in the gold plan because they tend to be the less cost. There are some people who are cost conscious in the gold category, but those are often people who for some reason have cost sharing reductions that have chosen gold over a silver plan for some reason. What I'm more interested in is making sure that we drive people. We want people to stay within the cost sharing reductions if they qualify. The 73%, whatever, that's one thing. But for those who get the highest levels of cost sharing, that's really where I'm interested in. And I don't know that it matters if this stays the same or something changes by $5 for a gold plan. And I don't know if there's a reason that we want to drive people to the value gold plans over the other gold plans. I don't know if there's a real value in that. I just feel like we're going to be looking in a context where there are going to be fewer plan designs for people to choose from. So comparisons will be easier. And I guess if we want to distinguish the value plan from the others, that's one thing. I just feel like where the action is going to be cost sharing levels for silver.
That's a great point, David. Thank you.
I don't disagree, David. I just wanted to go back to the goal because we went past it so fast. I just wanted to take a good look at it.
Well, it does sound like, people are not super concerned about gold. It might make sense to just leave it as is. So considering that, does anyone have thoughts on the silver designs? And I'll go to the summary slide. Lisa. If you're speaking, you might be on mute.
I'm sorry. I definitely agree with everything Dave just said. As far as like the silver 73, I definitely sometimes don't go with that and put them in a gold plan instead because the cost sharing, it's just not as valuable as it is in a gold plan because the premium is lower with the gold plan as a comparison. But I do like this lab decrease of 80 to 45. I was going to say I agree with what he's saying in the silver plans, but also the value bronze to see some of those copays come down as well would be good.
Thank you. Allison?
Yeah, was there a slide on the silver 73 base silver and bronze to demonstrate the AV impact of going from 80 to 4? Okay, yeah, that helps. Thank you.
I wanted to say one more thing. I'm a little concerned about the $750 drug deductible on some of these. And this is applying to brand name prescriptions that may be chronic condition or diabetes drugs. If there is nothing special tier or anything for chronic condition drugs. So that is a little concerning, that $750 drug deductible for brand.
Yeah, that's a good point. I will say that the silver 73 and base silver are, and I can for next time dig up a slide that shows this, but these two are the lowest enrollment silver CSR variants. So although it's unfortunate, it impacts fewer people than like one of the higher AV silver plans to have that kind of drug deductible. But it is unfortunate. David, yes.
Yeah, I just think we're effectively discouraging people from this plan. I don't necessarily think that's a bad thing. And because I do, the premiums for these folks are lower in gold. And the carriers have been more competitive this year. At least United Healthcare has been more competitive in the gold zone this year. So I don't know that this is a bad thing. What are the cost sharing levels for the deductibles for the drugs?
For gold?
No, for silver, for the silver cost sharing, like the
$750 for both base silver and silver 73. But then for the other two silver plans, I think I can actually have in the appendix for this.
Because that's really where.
Okay, so yeah, there's only it's $150 for silver 87 and $0 for silver 94, at least for 2025 plans, which we would propose. I guess the proposal here is to recommend that they stay the same as they did in 25. So
yeah, see that looks good to me at the cost sharing levels, and I think that our one of the focus we've had is how do we attract people to take advantage of, even if the premium's a bit higher, how do we get them to stick with the cost sharing because of the overall annual impact that it could have on their lives and their ability to actually access care when they need it. So that's where my thinking and concern is.
that makes sense. Yeah. Okay, so hearing that while it's unfortunate to have higher deductibles in these lower AV silver variants, it's not necessarily a bad thing to discourage people from enrolling in those plans because they're better off in the gold plan anyway. Looks like we have a comment in the chat. A lot of comments in the chat. Allison says, I think MHBE's decision support work group will address how to demonstrate the value of CSR 87 and 94 over gold plans. And yes, yes. I don't think we've talked in this group yet about the decision support work group, but that is coming up. My colleague Amelia will be facilitating that one. And so if you're interested, feel free to pop in. And I can send some information about that in my next email to you all. Justin.
Yeah, thanks. Whether or not it makes sense for most folks to be in a silver 73, and I grant that I think probably it doesn't make so much sense for many folks, and they may be better off in gold. I mean, I think we still probably want to try to design the best and most affordable plan we can under the constraints that we have with the AV. So I'm curious to keep talking about what we might tweak. I guess one thing that I'm bumping up against for really all of the changes at the end of the day is how we would explain them to folks. I mean, why take the copay down to 45 or whatever it was on the 73 plan, but leave the specialist copay at 100? I mean, is there a better? I mean, for some folks, presumably it would be better if that be reduced by some amount. Is there a place we could land in between here? And I have, not the faintest idea what the answer to that is, but I'm not, it's not clear to me that tweaking one all the way down without necessarily much of a grounding in utilization. I just wonder if there are other ways that we might go about it.
Yeah, that's a good point. Yeah, and the way that AV calculator works, like some things have more of an impact than others, and so tweaking down the lab copays may have less of an impact than reducing the specialist copays. But that's something, yeah. First, yeah, we can look a little more at utilization, and then also I can ask our actuaries what it would look like to try and have more of like a middle ground, if it's possible. Because I agree, specialist copays are pretty high in these lower value plans. Go ahead, Justin.
Yeah, I mean, and I guess I'm just using that as an example, but not necessarily an informed one. I mean, there may be, there could be another tweak, and certainly, going down to 45 on one doesn't mean you could go down to 45 on the other. Obviously, the value is different. But I'm just wondering if we really don't have much of a sense of how this is actually going to affect behavior. It's a little, I guess it just gives me pause, because certainly at the margins, when you play with one up or down, you're going to encourage or discourage people from actually using this care. And so maybe that's what we want to do, or maybe not. But I feel like I'm a little blind on that.
Yeah, fair enough. David.
Yeah, I just think what happens is once you get beyond 87%, people just go to gold. And it's less of it just feels like that's typically what people do, and that's where people find the best value.
Thanks. Yeah. Richard?
Hello, good afternoon, everyone. And this comment is in addition to what David just said. In my experience, at 73%, that means the person is also not getting much in the way of APTC, and they tend to go in the opposite direction. They don't tend to go to gold. They tend to go to bronze value plans with some pre-deductible cost sharing available. So those 73% silver plans have always been a no man's land, where the people who are 87%, 94%, they're comfortable at the silver level, or they might go to gold. And then the people who end up in that no man's land of where they make too much money but not enough to get more assistance, they tend to default to bronze, or they decide not to enroll in health coverage at all, depending on their situation. And another thing to keep in mind is this Access for Care Act, right? Well, no, they're not going to get any assistance anyway. So forget that I even mentioned that.
Thanks, Richard. Well, thanks everybody for the feedback. Yeah, I think so. I will, let's see, move along in the slides here. I will, yeah, so public comment, if anyone else wants to chime in. Oh, yes, David.
Yeah, I'm sorry, I just have an idea, and this would be information I would ask from the carriers to provide to us. When we think about social determinants of health, and we think about how do we incentivize people to utilize their coverage in the way that's best for them. I know and I don't think we have this in the marketplace, but on my health insurance, if I answer this survey, I get this exam, I have this test done, I get $5 off of my copay I get my primary care at $0, and I get $5 off of a specialist visit. And there are incentives that are built into the plan based on my behavior. Now, I don't have to do any of it, right? But if I do it, I get a reward. And when I'm thinking about the value plans and I'm thinking about, but I don't know, are those effective? I don't know if carriers like doing that, if it's a waste. I don't know anything about them. I just know that in my own personal experience, I want that $5 off and I like that $0 primary care visit. So I do all the things. And when we think about encouraging people to address their social determinants, is there any value in those kinds of incentives in a plan? I don't know. And I honestly just don't know, but it was just something I was thinking about.
Do any carriers have any information on that just off the top of their heads? I see Tim's hand is up, Allison's hand is up. Yes, Tim, go for it. I can't hear you. You may be on mute. I don't know if you're on your phone. That might make it so that there's something else you have to do special to. Right, doesn't work. All right. Well, feel free to share something in the chat and we'll read it out. In the meantime, Allison.
Sure. As far as, utilizing services and mitigating the issue of affordability and, $35 copays for office visits, I would say that much of our care management, especially targeted towards conditions where there are health disparities, that a lot of that care management is at no cost, and that if someone is eligible for a program and participates, it's at no cost. And that's an incentive to work with providers, work with health education specialists, to manage their care. And ultimately, the goal is to narrow and eliminate disparities. So that's one of the ways we try to incentivize our members, especially in conditions where there are high disparities.
But my question is, do those exist in the marketplace on the exchange? Because in all my years as a navigator, I've never talked about anything like that when I'm talking with consumers about plan selection. Is that available to people in the marketplace?
Yes. Yeah, that's available for all lines of business. There are certain clinical criteria. It's especially targeted at individuals that need additional care management. But that is available across lines of business.
So then my follow-up or my idea about that is there could be some education for those of us who assist consumers to understand better, because I know, at least in my world, I think Richard will agree with this, that we see a lot of people affect, in that social determinant category. And for us to have a little more knowledge around what's available to support the consumer, that would be useful.
Sure, I can look into that.
All right, thank you both. Tim has posted in the chat here. I'm skeptical that incentives that lower cost shares actually have a big impact. Speculate that, especially in this population, it's unneeded complexity. Most folks struggle to understand coinsurance. Suggest we keep design as simple as possible, i.e. fixed cost shares. And that's definitely, I hear that point, Tim, thank you. And Michelle also adds, we can, on the incentives, that we can include information on that in the annual carrier videos for consumer assistance workers. So great, thank you.
I have a quick question, Becca, for David. David, are you talking about incentives that will lower the cost sharing more, right? Or are you talking about incentives that people will receive, like gift cards or something like that? Or
no, in my case, because I do all the things, I get a $5 off on my specialist copays, and I have specialists now. and I get a $0 primary care. So I'm thinking specifically for the value plans, and I'm thinking specifically, for people who might have, more need for services, right? The social, diabetes and different things like that. I mean, if they're already there, that's great. But I was actually thinking of a lower cost based on participation in some kind of a management program.
To incentivize engagement, right?
Yes. To incentivize people to get that annual physical, to do that. Like in my case, it's an eye exam, it's the annual physical, and based on my age, they suggest tests for me to get, right? So they proactively push the preventive care.
Okay. Thank you for clearing that up. I mean, one thing that I would suggest is maybe that we engage with the new health coverage assistance team on that front as well, right? Since they're the ones who are supposed to be providing a lot of education to all Marylanders.
Thanks, Richard. Lisa?
Thank you. I have a question for Allison. I know that Kaiser Permanente has their own internal financial assistance program. I wanted to know, because some people that are on bronze plans that have higher co-pays or deductibles they have to meet, I know that sometimes we have suggested, and I do Medicare as well, that they apply for the Kaiser Permanente internal financial assistance program. Does that apply? Two questions. Does that apply toward prescription drugs as well as co-pays for doctors and specialists and other things? And what is the income limitation for that kind of a program?
Hi, Lisa. I would need to look at the plan design. If you want to email me offline, I can address that. I don't want to pull the attention away from the work group's focus on the value plans.
Okay, I will do that. Thank you.
All right, thanks everybody. So in terms of next steps for this group, our next meeting is on August 6th. And during that meeting, we'll have a speaker from the Maryland Department of Health Office of Minority Health and Health Disparities to talk about Maryland-specific health equity priorities. And I'm also trying to get a clinician to come speak. And then, as I mentioned, we'll present some data analysis on I think specifically it was on age and income breakdowns for the value plan enrollment, and then maybe also about premiums. And then now we have this question of utilization. So anyway, we have, a couple additional meetings to have, to workshop the plan designs, have a couple more presentations, and then the September 3rd meeting will be our last opportunity to vote on the recommendation. And then that will be kind of the proposed recommendation for the value plans for 2026 that we'll bring to the Standing Advisory Committee and to the MHPE board. And then those won't get finalized until after the AV calculator comes out in December, and we'll make adjustments if necessary at that time, and then the board will vote to finalize the designs in early 2025. So, and I see in the chat, Ken says, recent surveys show lack of usage for people enrolled in plans through the exchange. We need to think through cost adjustments if they don't really address usage. Okay, yes, good point. Thank you, Ken. And then Nikki asked if the slides can be sent out. Yes, I'll send these out. David.
Yeah, I just want to emphasize the point that Ken just made, which is maybe we should, I don't know, this has come from data, But if we had ways to look at the data to see what actually did affect a behavior change, right? Because I think, I hate it when somebody comes back and they, we're shopping for the next plan and they brag about not having used it once, right? So I feel like Ken's onto something there with this notion of what is it plan design that motivates consumer behavior changes in the way we want them to or not? Is that beyond what we're looking at here anyway? But maybe it's a topic for discussion for another group or something, because I do feel like we really want people using their coverage. When we're talking social determinants, which is what I keep coming back to, and the need to address the disparities, that's a behavior. We're looking for behavior change, right? We're looking to change the behavior of people who don't trust the healthcare system writ large in many cases and have good reason not to. So I think it's something really worth looking into and following up on and pursuing.
Yeah, that's a good point. And I think probably if we want to look at utilization, we'll end up having to look kind of more broadly than the value plans, or more broadly than just the standardized value plans, since we still only, we're in the first year of the standardized value plan. So we wouldn't be able to see changes in utilization based on cost sharing yet. But it's definitely a really good point. And it'll be good to dig into some utilization data. I think, so Tim's hand is still raised, but I believe that's just from before. But Tim, please send a note in the chat if there's another comment you'd like to make. Otherwise, okay, looks like we're good from Tim. Any other comments before we close today's meeting?
Becca, just a question. For August 6th and 20th, are you planning on additional modeling? Will we be looking at the impacts of different cost shares for office visits, or I'd just like to get a sense of what's planned for those two sessions?
So I guess my takeaway from what's been discussed today is that, I think I would have a conversation with our actuaries about the impact of making any other kinds of changes on the plans, but I would be cautious about doing that just because like the balance is so delicate. And I think, depending on what they say, perhaps there'd be another round of designs for the group to consider. Otherwise, we can talk more now even about how people feel about this round of designs. Sounds like probably we'll keep gold the same if we were to go with this, round of designs. But I don't know that there is, that I have a specific idea of another type of design to come up with for the group to consider. If that makes sense. Unless there are things that people feel strongly about wanting to see. And so since people haven't had much time to sit with these designs, probably what will happen next time is we'll hear from the Office of Minority Health and Health Disparities, and then we will maybe have another opportunity to talk about these same designs once people have had more time to think. And then I'll also let people know what the actuaries have to say about how much room there is to, make other changes instead. Okay. And Richard asked Ken to share the survey with the group, and actually I'd be interested to see that as well.
No, definitely. I think there is a lack of engagement issue that has been confirmed in all of my meetings with the FQHCs who accept medical assistants as well as, all the qualified health plans. I know that the president and CEO of Baltimore Medical System, the largest FQHC in the state, Shirley Sutton, she told me in a meeting that they have an issue of over 30% of their client base not being engaged, whether it's through medical assistance or a qualified health plan. And these are the people who churn in and out of the system. And we both agreed that that's lack of engagement is tied to lack of proficiency in health literacy, is tied into proper education not being given, etc. And so all of these are tied together. And I say that because oftentimes the outreach that we do is oversimplified when it comes to tying it to enrollments. There are a lot of complicated forces at work. So I would definitely be interested in seeing the results of that survey.
Yeah. Ken, I'll connect with you offline to see if I can maybe share whatever you found with the group when I follow up. Okay. Thanks everybody for coming today. Appreciate the feedback. And I will see you on the 6th. Yeah, feel free to get in touch, and see you next time. Thanks everybody.
All right, have a good one, everyone.
Thank you.
Thank you.
Thank you.